You're dispatched to 1600 Courage Court for an older man who has fallen. You arrive to find Mr. Hishari, an 81-year-old man, lying on his floor. His two sons explained they visited their father last night and left around 7. When they returned this morning, they found the patient lying on the floor next to his chair. He is unable to explain what happened, and because he lives alone, no one is sure how long he's been on the floor. Patient is awake and responding to his sons, but they say he's not acting right. You'll get that all the time. They describe him as very sharp, but today he keeps getting their names confused. They say this only happens when his blood glucose level is low. Patient has type 2 diabetes. So, he's responsive to verbal stimulus. Lying on the floor, clean, good airway, breathing's good. What are some possible causes that have resulted in Mr. Hishari being on the floor? Alright, low blood sugar. He is type 2 diabetic. Alright, stroke, possible CVA. Just a fall. Alright. Altered level of consciousness. If you really wanted to get real deep into it, you may think UTI, something like that, because he's got altered level of consciousness. He's an older person. What's one of your most valuable assessment tools that you can use when you're on scene and there's family members around and you're assessing neurostatus? Okay. Number one, what is normal? How does he normally act? And number two, when was the last time that you saw him acting normal? Right? Why is it important to get that baseline?
Because if it is a stroke, how long has it been going on?
Okay.
They could normally be altered.
They can normally be altered. We need to know how long it's been going on. We don't know this patient from Adam's house cat, right? If we see this patient, we may automatically start stereotyping, oh, this is just an older person, lives by himself, he's kind of cuckoo, kind of lost some thinking and stuff, so we don't really know, right? There's a lot of older people, just because you're an older person doesn't mean that you're going to have dementia, or it doesn't mean that you're going to have altered mental status, right? I know some 90-year-old folks that go to my church that are sharp as a whatever sharp. How would you prioritize these causes? So the causes that we've thought about, what are we thinking? What's the action we need to be taking? All right, vital signs and sugar first. So we definitely want to keep in the back of our mind worst case scenario, right? But we get to that by eliminating what? Other possible factors. You obtain the patient's vital signs. As your partner obtains his glucose level, you continue your assessment and determine that he is quite confused. He is alert and oriented to person and place, but is unsure of what day it is and cannot describe the events leading up to your arrival. Now, is this part right here, is that... Okay, so it would be a concern, but there are some perfectly oriented people that couldn't tell you what day it is, you know, especially when you're retired and you don't really have to keep track of time, right? So you definitely want to assess a little bit deeper. No signs of trauma. While assessing his pupils, he takes your pen light and tries to shave his face with it. He also seems to use inappropriate words for common household objects and appears frustrated that you can't understand him. Okay, so we've gotten a little bit deeper of an assessment, right? So is he just crazy, or is this something that's actually affecting his mind, trying to use your pen light as a razor and trying to talk to you and he can't? It's actual symptoms, right? He's symptomatic. So, level of consciousness at this point, after 5 minutes. GCS of 14, person, place, but not day. All of his other vital signs, they're not too bad. Respirations are 26 breaths per minute, so that's a little on the high side. He's 98%, but his blood glucose is 100 milligrams per deciliter. Not low, right? It's pretty good blood sugar. What do you think could be the patient's underlying illness, injury, or condition now? So what have we done? We've ruled out blood sugar, right? We've gotten a little bit deeper of an assessment, and that's how it works. That's how you form your differential diagnosis. You form what could be the worst case scenario, what could be the next. What is the easiest to assess, what can we figure out first, But now we're probably thinking more of what? CVA, right? Some type of brain injury. Do your assessment and treatment priorities ever change? You got to look at the grand scheme of things. The grand scheme of things is, had it been a low blood glucose, his son left him last night for whatever reason, took his insulin, forgot to eat this morning, fell on the floor, something like that, might be something that we could maybe give a fix to, right? But now we're looking CVA. He's showing some mild symptoms, all right? It's not a massive CVA at this point, but we don't know if it's embolotic or hemorrhagic, right? So we're going to have to probably put a little bit more of a priority on this so it doesn't extend further. So, given this patient, what are your appropriate interventions? Definitely, rapid transport. All right, heart monitor, stroke system, high flow oxygen. Well, he's on nasal cannula. The book says high flow oxygen, but I'm going to if he's already having issues with common objects and stuff, I'm probably not going to do a whole lot more than what's necessary. Definitely want to get an IV. Have that ready. What else? There's one thing you need to do before you call the stroke system and before you get them to the hospital. Alright, so you want to do that. So you want to do either, you could do your LA stroke scale or your Cincinnati stroke scale. The CPSS is probably the easiest one to do because it incorporates what? 3 things. What are they? And speech, right. Your fibrillation check sheet, right? We can't tell if it's a hemorrhagic or an embolic stroke, right? In the interest of time, you place your patient on the gurney. I like stretcher better. Obtain IV access. Administer normal saline, draw blood, perform an ECG, all your basic steps. You also complete the fibrinolytic check sheet. You ask one of the patient's sons to accompany you and provide more information regarding his medical history. Patient's son tells you that his history includes AFib. What's that going to maybe start cluing into? Yeah, definitely. Probably has some type of embolotic stroke. But now that doesn't necessarily mean that that's what it is, but this is helping us form our differential diagnosis. And then the patient takes aspirin, diltiazem, Coumadin, and glucophage. So if you were picking this patient up and he hands you this list of medications, what are these medications going to take? What's aspirin going to take? Either he's on a cardiac history or maybe the doctor's just put him on a prophylactic 81 milligram aspirin to take every day, right? Diltiazem. What's another name for that? Cardizem. Why is he taking that? The AFib, right? Coumadin. Blood thinner. Most people that have AFib, chronic AFib, they have to be on some type of anticoagulant therapy, right? Blood thinner is not the most appropriate word, but it is what it is, commonly known as that. What is the other name for Coumadin? Warfarin. Anybody know the antidote for warfarin? Coumadin? Vitamin K. And then glucophage. What is glucophage? You can just look at the name of it and it's got the word what in it? Glucose. Right? So I'm thinking maybe this is some type of oral anti-diabetic medication, right? Or diabetic medication. Patient has no drug allergies, has no recent history of illness, and has been compliant with his medications and diet. Why do you think it's important for the hospital to know that he has been compliant with his diet? Okay.
So there's no problem.
What did I just tell you the antidote for Coumadin is? Vitamin K. There's a lot of foods that you take or that you eat that they're going to have to restrict because of vitamin K. what is the potential consequence of reversing the actions of Coumadin? Blood clot, right? And then what did you say just a minute ago about diet? Right. She said that by him being compliant with his medication and his diet, it shows that this is an isolated event, right? That this is not something that occurs all the time, and so this is something that we should probably take a little bit seriously. So he's still at a 14 GCS, skin pale, warm and dry, vital signs, pulse 92, and strong and irregular. All right, maybe to be expected with somebody with chronic AFib. Blood pressure is pretty decent. Respiration's 24, and SaO2 is 98%. Would you choose to place this patient in manual inline spinal precautions? That's kind of one of those, you danged if you do and you danged if you don't, right? I'm probably going to do a pretty decent assessment on him, but remember, and that's one thing that we're going to hear when we get into this neuro stuff, that time is brain, right? Time is brain tissue. If he doesn't appear to be having any trauma, which the assessment said no signs of trauma, I'm probably just going to get him on up and get him to the hospital. Not to mention we're going to impair breathing and all that if we lay him flat. What places this patient at greater risk for CVA? We've already talked about it because you guys are smart. What was one of the biggest risks? The AFib. During transport, the patient's condition did not change. You continue to monitor his mentation, vital signs, and deficits while en route to the hospital. Provide a prompt radio report to the receiving facility and deliver your patient to the emergency department without incident. All right, not a whole lot of change on his vital signs here. What other important considerations relate to total patient care? So we've looked at all the clinical aspects. We've taken care of him. We've done all of our skills with him. But have we considered just the fact that he can't communicate with us where he normally could? He's very frustrated and probably pretty doggone scared, right? Son's probably pretty scared. So you've got to remember those psychosocial aspects as well. Remember, we're doing this for complete patient care. We're not just doing just the skills. Makes you may be a good paramedic clinically, or you may be a good nurse clinically if you can go in and start an IV with your eyes closed in the dark upside down. But if you can't make that patient feel better emotionally, you can't get that patient to calm down, or if you can't at least be empathetic with that patient, then you're not providing total care. Okay? So, follow up. CT scan showed a mild stroke in the parietal lobe. Patient was not a candidate for fibrinolytics because the onset of his stroke couldn't be determined. Still, we're still going to do our thrombolytic check sheet. He soon returned home with the support of his family and full-time nursing care. Because you rapidly recognized his stroke and transported him with the appropriate sense of urgency, the emergency department nurses and doctors were able to promptly confirm the type of stroke